Welcome, everybody. Rush University Medical Center Renal Biopsy Conference for February 13th, 2025. This conference is being recorded. If you're not on our email list and found us through Twitter or X or whatever else, Blue Sky, and you want to get on our mailing list, just send us a message and we'll include you. As I mentioned, it's being recorded. These are all available on our YouTube channel, and they're categorized by the general topic, so it's kind of fun to go in there if you're interested in looking at any specific topic. Today's case is Dr. Baxey's. It's a fun case with a lot of interesting, possibly twists and turns. We have nothing to disclose, and patient privacy has been preserved as usual. I'm going to hand it over to Pravir, who will give us the history. Pravir.
Perfect. Everyone can hear me okay, hopefully. I'm just going to share the PDF of the case presentation in the chat for those who want to open it. All right, there we go. So the case today is a 46-year-old Black woman who presented to our outpatient clinic for referral and evaluation of new proteinuria. So on, talking to her, she was really not unhealthy at all. She was without any other medical issues for many, many years. She was seeing just her primary care doctor once a year. And all of a sudden, 6 months ago, prior to when I saw her, she had developed a scalp rash. And she was worried. She was referred to dermatology by her primary care doctor. As part of that workup, based on the appearance, she had a serological workup done, and her ANA was positive, and she was told that she may have discoid lupus, and she has to go see a rheumatologist. So she sees a rheumatologist after that, and she has some labs done. Her creatinine is 0.85, which is on par for her baseline based on the labs we had before. She gets serological workup that shows a positive ANA, titer of 1 to 80 in a speckled pattern. Otherwise, her serological evaluation was normal or negative. Complements, anti-double-strand DNA, anti-Smith, everything was negative or normal. She did get urine testing that showed 2+ protein on dipstick, but she had no hematuria or no RBCs, but she did have a spot urine protein to creatinine ratio of 0.85. After evaluation and looking at the totality of this, rheumatology did not feel that this was completely consistent with discoid lupus, but did refer her to us for the proteinuria. So she's gone from PCP to derm to rheumatology, and then finally to me. When I saw her for the first time, she had no complaints, no joint pains. The rash that she had before had already resolved. She had no sores. She had never seen a nephrologist, never been told of abnormal protein in the past, but she wasn't sure that she's had routine urinalysis done, but she's had lab work done that has always shown more or less normal labs. She denied any medication use over the counter or prescribed, no NSAID use. Review of systems really was negative. She had the rash that was resolved, and per rheumatology, this was not consistent with lupus. She had no history of prematurity, no prior pregnancies, no surgical history, no major hospitalizations, social history, non-smoker, never used drugs, and then did identify as Black. Family history was important, and she had a family history with a sister with lupus, with kidney involvement, unknown exactly what medications or how bad her lupus nephritis is. And she also had her father also required a heart transplant due to amyloidosis. He has unfortunately passed away, but she does remember that he required a heart transplant. But he does not. She does not remember if he had any kidney issues. So examination, her blood pressure is 120/80, and that's kind of her baseline. Her BMI is 23. On exam, she was well appearing. Her age, there was no rashes, no lower extremity edema, really not anything very pertinent on her exam. In terms of labs that were collected, her sodium was 138, potassium 4.2. You can see the bicarb 24, BUN 12, creatinine 0.85. Her calcium was normal. Her albumin was 3.6 with the total protein of 6.8, and her ALK phos, AST, LT, and bilirubin were all normal. She had a CBC drawn. Her WBC was 6.5 with a normal diff. Hemoglobin was 11.5, and platelet count was 250. Her UA that I repeated again had 2+ protein without blood on dipstick. There was no RBCs or WCs on microscopic exam. and a repeat UPC ratio was about the same, although I added on a UAC ratio that was shown there 0.55 with the corresponding UPC ratio of still 0.85. Serological evaluation, most of it which was done prior to her coming to me, but ANA was 1 to 80 speckled pattern. Anti-double-strand DNA was less than 1. C3, C4 both are normal. SSA, SSB negative normal. She had an anti-Smith antibody negative and an anti-PLA2R serum antibody that was negative. A kidney ultrasound was done as well that showed 2 kidneys, one right 10.5, left of 12.0. She had no lesions, stones, no hydronephrosis.
Any questions for Pravir? Okay, so we're going to jump to our poll number 1. What would you do next? Would you do a kidney biopsy? Would you just add an ACE and an ARB and monitor? Would you do genetic testing or something else? Remember, we can't see who's voting for what, so let's get a good representation here.
Except we'd see Hamoud's. Pretty good. Few more. All right.
Okay, you want to show the results? So we've got over half the patients want to go directly to kidney biopsy. About a third would just want to watch the patient. And 14%, only 3 people want to go to genetic testing. I think that's interesting. That's been our big move in these conferences. More and more and more, we keep saying, let's do genetic testing. It might preclude something else. So I want to hand it over to Casey and tell me what he thinks is going on in the case, Dr. Gashti, and give me, we'll keep this poll up and you can give me the arguments for each of these.
Okay, so this is a 46-year-old woman who basically comes to us she has proteinuria. She has about 850 milligrams per gram of protein and about 550 milligrams per gram of albumin. She has a mildly positive ANA. She has a rash on her scalp, and her sister has lupus. So these all kind of give you some clues that maybe she does have some autoimmune disease. Maybe she does have lupus, but it hasn't really serologically manifested itself. So it could be a latent lupus with some kidney manifestation. So if we do a kidney biopsy with lack of serologic activity, negative double-stranded DNA, normal complements, I don't really expect to find a proliferative lesion. It would be surprising to me if that's the case, but maybe they're a subnephrotic membranous or even more likely a mesangial proliferative type of lupus could possibly be found. She could also have a lesion in her kidney that's not lupus related, so maybe we won't find any mesangial deposits, and she would have maybe an APOL1 related disease. I don't see that was tested. She's 46, African American. I can't remember if she has hypertension. Forgot to look. She's not.
No hypertension.
No hypertension, but APOL1 disease is still on the differential. We would find possibly global glomerulosclerosis with some proteinuria as a result of that. I'd be interested to see what her APOL1 status is as well. But, there are some clues here that there's an autoimmune disease happening. The ANA I could ignore is pretty low, but the scalp lesion, I'm surprised Derm hasn't biopsied that. But, I'm going to go with lupus. ATTR amyloid. Okay, so I'm gonna stick with those two things. I'm gonna say that she probably has a lupus lesion. You wanted me to go through the polls. So kidney biopsy. Yeah, when I see a young person with ANA positive, some skin findings, and proteinuria, I don't want to go to a biopsy because we have in the past seen patients who have had proliferative lesions in their kidneys and their creatinine is normal, and not a lot is happening in the UA and you get fooled and you find necrotizing lesions. So you want to kind of catch those, especially in a younger person. So I think renal biopsy is appropriate. These are not obviously mutually exclusive. We do these things simultaneously. Adding an ACE or an ARB, she has proteinuria and her blood pressure, as long as it can handle it, ACE and ARB is an appropriate thing to do as well. The genetic testing specifically, the APOL1, as I mentioned. And it would find if, there are any other potentially tumor type diseases, although this is more glomerular based on the ratio of albuminuria to total proteinuria. So I think that the percentage of the poll is the way I would go. I'd probably add an ACE and do a kidney biopsy. I don't know what other would be, but genetic testing. If I do a kidney biopsy and get an answer, I may skip the genetic testing, but outside of APOL1 status.
I think the genetic testing is there because of her father. Did you hear that whole story?
No, I missed that.
Okay, her father had a heart transplant for
heart
Emily.
transplant. Yeah.
Gotcha. Okay.
And that's why the ATTR was brought up by Dr. Reen.
That's why I was like, wow, how are we going to amyloid with this?
Roger?
Yeah, I don't know. I don't know how I feel about that. I don't know. I mean, it's a cardiac. It does have renal involvement. It's possible. So yeah, I guess genetic testing would help with that.
Yeah, but you only the idea is you get one and you get one first. So does that, knowing that heart disease, sway you to do that first?
I'll do a kidney biopsy.
Okay.
Amyloid, we can still that. We'll find that in the biopsy too.
Roger?
Yes, Dick.
Well, there's certainly no urgency to do anything with this benign presentation, so you've got time on your side. When the initial presentation was given, I wondered about psoriasis. If it were psoriasis, then, IgA nephropathy would boost up pretty high on the list. The absence of leukopenia in a Black woman with a positive ANA makes lupus less likely, because there's a strong association between lupus and Blacks due to the Duffy null. And I must say, I checked genetic testing because the thing I'm worried the most about is amyloid, a familial amyloid. I would like to ask Dr. Reen if he would do a skin biopsy in this patient other than a kidney biopsy, because the patient had a skin lesion, is thought to have lupus, and a positive skin biopsy would certainly make the lupus issue rise up in your differential. And Dr. Reen has mentioned earlier the value of skin biopsy in lupus. I'd like to hear his opinion.
I remember we had discussion on ASM community on that. It's a non-full house, non-lupus full house membranous nephritis. So I had suggested that do immunofluorescence study on skin biopsy, and if it is positive, and that may in future turn out to be a lupus disease. Now, the question I was asked, and I haven't found the answer as yet, is the specificity and sensitivity of the test. I still don't know how to answer that question. But if this patient shows which I doubt very much it will show, non-lupus full house nephritis, then I will consider kidney biopsy, because then I can think if it is immunofluorescence is full house positive in skin biopsy, then I'll watch this patient very carefully for the development of lupus. That was my rationale. I hope that answers your question, Dr. Glassick.
Yeah, that's fine.
So Dr. Glassick had mentioned that the lack of leukopenia sways him a little bit away. We've always felt fairly strongly about this, whether you call it latent lupus or whatever you want to call it. The paucity of lupus clues, yet on biopsy finding a membranous pattern, and the latent is that sometimes they'll develop lupus later. But we see a lot of patients that don't really fulfill criteria for lupus. A few suggestions and you biopsy them and they've got kind of a membranous pattern. So I thought that was interesting. As far as the psoriasis and IgA, does the lack of hematuria, if I told you this patient had psoriasis, Dick, which I don't know, but no hematuria, how'd you feel? How would you still feel about IgA?
It wouldn't influence me too much. About 20% of patients with IgA present with proteinuria only. It would be nice if but it wouldn't dissuade me from
Okay.
including IgA in the differential diagnosis because we don't know the nature of the scalp lesion. Now, if she had a lot of alopecia along with the scalp rash, that would be different. But if it was just a scaly rash in the scalp, that could easily be psoriasis. And we don't have a biopsy, so I'm just sort of presuming. And whenever you see psoriasis, you've got to think of IgA.
Dr. Roger Sakaran, you had put something in the chat. You want to elaborate on that a bit?
Yeah, hey Roger, can you hear me?
Yep.
Yeah, sorry, my video is not working today, but this feels more like this entity known as MGMID, which is membranous-like glomerulopathy with masked IgG kappa deposits. It's a rare entity seen in less than 1% of biopsies, but patients kind of present this way, where the hallmark is they do have this non-specific ANA positivity, and they do have this subnephrotic range proteinuria. And when you do biopsy them, these are predominantly young women who have some non-specific autoimmune disorder, and they do have a mesangial-proliferative pattern of injury. They do have a C3 dominant pattern of injury, and you got to do a pronase IF, which restricts it to IgG kappa, but it's really not an MGRS lesion. And if you do the pronase IF mass spec, it lights up for serum amyloid P protein. So I was thinking that this case fit more like MGMID because she kind of hits all the boxes of that disease entity.
Yeah, it's one of those things that it pops up. You did, but most people, it's not something I think of initially. It's something I think of later. It's like the ITG thing. You never really expect it, but then it does pop up once in a while. So that's always a good point, but it's real important to stress that it's not felt to be a monoclonal gammopathy of renal significance.
And therefore, they do not need a bone marrow biopsy. A lot of times, the bone marrow biopsies have been pursued in that disease, and they're negative.
Yes. Right.
Bill, what did you vote for?
I wanted to. It's very easy to just say genetic testing because with Natera you can get them all. But if anybody picked genetic testing, I'd like them to be more specific and say which one they're really thinking of. Because I think is it going to be an outports type of situation? Lack of microscopic hematuria is a little bit less likely.
Amyloid.
Same thing with thin-based membrane disease, a little bit less likely. If it's APOL1 mediated, I still think we would need to do a biopsy because, even if she does have APOL1 genetic abnormality, she could have an underlying glomerular lesion where APO is just the risk factor for making it worse. And so the only thing I think that we would pick up on genetic testing might be one of the familial amyloids. And so that is possible, but even if it was that, like if we got a transthyretin that was positive, I still think I would do a kidney biopsy anyway, just because it's so rare to have renal involvement with that. And especially if the cardiac issues are, not evident, then I think I would still need to do a kidney biopsy to really prove it. So I'm not sure that in this case, genetic testing would obviate my need for a kidney biopsy is my point.
May not obviate, but it's always kind of interesting the order that we do these things in, because I think you're going to, I imagine it's hard to believe you're not going to end up doing all of these, to be quite frank,
Yeah, sure.
nowadays. It's because it's so accessible, but
Roger?
I'm going to go ahead.
Roger?
Yep.
The chat room says that the rash resolved with an ointment treatment. Of course, that raises the possibility, if it was ammoniated mercury ointment, that this is mercury toxicity.
Nice.
This was advertised as a red herring conference, so I'm using every red herring that is available.
No one, baby, no one.
We need to know whether the patient had proteinuria before or whether it developed after the treatment with the ointment.
Pravir, did you drive to the patient's house and look in their
No,
medicine cabinet
no,
like Dr.
I
House
was,
would and see if it's mercury
no,
containing?
no, the fellows are out, so I didn't have my fellows going into the room. I saw this patient by
Okay.
myself.
You can check a mercury level,
Yeah.
and it can be positive.
Yes.
Unfortunately, joking aside, I didn't have one of the problems was we didn't have any prior urinalyses.
Yeah.
So, but that's a great point. Yeah, I'll see if I can pull up the ointment, but it was very short term, but still.
Never know.
Yep.
So Pravir, I'm gonna head back to you. Tell us what you did.
So I'm glad there was some discussion here because what I did is kind of what I think Dr. Glassick mentioned was kind of I had time, right? I mean, this patient was normotensive, inactive sediment, normal creatinine with some non-nephrotic range proteinuria. So what I did is I did put her on an ARB and I said, likely we're gonna have to get a kidney biopsy, but let's get some genetic testing first. And I was focusing on two things, and I think Bill mentioned these were the APOL1, and I was also interested in this amyloid history, which she couldn't elaborate on too much because she didn't know. And sure enough, I got the Natera screen, and this is what came up. Can't make this up. This is so while we're waiting, and she was gonna go out of town. I said, a biopsy is not emergent. Let's get some more information. And so sure enough, Natera comes back quite quickly. It was quickly this time around, and she got it drawn, and so it comes up with these two positive hits. One is for her hereditary transthyretin. Again, probably could be expected now with her family history of her dad who had a cardiac amyloid, which was hereditary, probably, of course. And then she does have two high risks. It's interesting. Sometimes this is a little tricky to read the way they report it, but this is two G2 risk alleles. So she had two she had two high risk alleles, both being G2. And so now she has two APOL1 genes, and she has positive TTR on genetic testing. So here we are now. So I guess we're next to the next poll.
Next poll. So, what would you do now if you hadn't done the kidney biopsy? Well, you haven't done it because this is what you have. Kidney biopsy, again, just watch a conservative therapy. These aren't mutually exclusive, of course, but this is you get one choice here. Refer to cardiology and neurology for a transthyretin diagnosis, or something else like refer to an APOL1 trial. I mean, what are the odds that both of those are going to come up? I think that's pretty incredible.
I know that we've often said that we're going to try and one day present a biopsy conference where we don't have a biopsy and we show that genetic testing was not needed. My God, this is biopsy conference. I think we're going to need to do it.
Yeah. Oh boy. Now you got to do a biopsy.
Not as many. Come on, let's go. A few more.
Well, yeah.
Yeah, yeah, right.
Yeah, I think it's kind of swayed, so we can end it there.
Yeah, I mean, yeah, you need a kidney biopsy, and I
Yeah.
think that was all along. And but I thought it was pretty interesting that there's an algorithm. What do you do first? Is it going to preclude one or the other? I think regardless of what you found on a kidney biopsy, did it first, you'd still do the genetic testing because of her father's history, and you want to know what's going on with her. So it's all good answers.
I suppose, Roger, you could make an argument against a renal biopsy here with a known genetic diagnosis of ATT amyloid and a family history. You'd treat her for ATT amyloid and wait and see. There is no treatment for APOL1. I mean, you said enroll her in a trial, but that means she might get a placebo. The cardiologists and neurologists aren't going to say anything except, maybe do a cardiac biopsy or something. I have no idea what they're going to say in an asymptomatic patient like this. But, I mean, obviously the kidney biopsy is something that probably most of us would do, but whether it's going to help the patient any, I don't know.
Well, let me get back to Dr. I'm sorry, Mario.
No, along the lines that Dick was mentioning, you can get a so-called prealbumin level, which is actually TTR circulating in the blood, which is something that is being done. The other is a pro-BNP level, which correlates also with TTR cardiac involvement. the echo, looking for the speckled pattern. As Dr. Rim pointed out, the test is the cardiac MRI. And if the cardiac MRI is abnormal, then the next step is an endomyocardial biopsy. But we need to keep in mind that the involvement of the kidneys by TTR amyloidosis is rather low. So I wouldn't know what she's got in the kidneys without a kidney biopsy.
Well, you are the king of kidney biopsy. I don't think you've ever voted anything except kidney biopsy first, and I respect that and I like that. So you are consistent, Mario.
Dr. Rubin, just to elaborate on kidney involvement and ATTR, initially we used to think it is rarely involved, but there are some variants which actually predispose to the renal involvement and ATR, and it is as high as 15 to 20%. So it is not as rare. APOL1 is interesting. I have a number of patients with the APOL1 related kidney disease, but all of them had hypertension. I don't know how many patients will have normal blood pressure in that situation.
I agree.
That's a really good point. I'm glad you brought that up. I'm going to head it back to Dr. Gashti. And, your number one diagnosis was a lupus-related lesion. Has any of this discussion swayed you from your number one diagnosis?
Yes. The testing, the fact that I missed the family history of ATTR, that swayed my decision as well. But the genetic testing with APOL1 being positive and ATTR being positive, it doesn't sway me from doing the kidney biopsy. I still want to see what's going on in the kidney, because if we find amyloid, the treatment's different. If we find mesangial deposits, the treatment is different, and if we find nothing, just glomerulosclerosis, then that's more an APOL1 directed therapy. So I still would like to have a kidney biopsy, but now I'm thinking.
My question is, does it?
The scalp lesion is not really discrete numbers, and all we have here is basically a family history of lupus plus an ANA positive. I'm thinking more along the lines of APOL1.
Yeah, my specific question, does it sway you from your original lupus histologic prediction?
It's not my differential. I don't know if it moves from maybe 1 to 2.
Okay. Anybody feel strongly about one of these or the other? Anyone still do a rectal biopsy for amyloid? I don't think so. I think those days are over. Fat pad biopsy, Dr. Glassick likes to make the case that it's underutilized. We haven't had a lot of luck with it. The old rectal biopsy was pretty rough. These patients, they'd come back with purpura and everything else. But
the fat pad biopsy.
I agree, Roger.
Yeah.
I think rectal biopsy is a museum piece, and it shouldn't be considered. I've had some serious bleeds from patients with amyloid from the rectum, but an abdominal fat pad biopsy is simple, safe, and fairly sensitive. I don't know what the sensitivity is for ATTR, but it's reasonably sensitive for AL and SAA. And it's so easy to do. And if it were positive, of course, it would largely avoid the necessity of doing a kidney biopsy. But I probably would go directly to a kidney biopsy in this case.
Yeah, I'm not convinced that this patient couldn't have two things. I know that's totally against my my worship of Occam, but a little amyloid, a little something else, you never know. So I don't see how we're going to get around, even with genetic and fat pad or whatever else, a kidney biopsy. And this is biopsy conference, so I think it's time to go to the wheel and read it.
Just a comment on fat pad biopsy. I think sensitivity is pretty good, about 70 to 80%. But if done properly, one of the problems with fat pad biopsy, it is not done properly. At least in my institution, it's not done properly. It's not deep enough to give the results.
Why don't you elaborate on what is a proper, seriously, because
I have to look it up, but I know that we have discussed it before also, because those are very superficial biopsy. I can look for it and send it to you later on at the conference.
Did the wheel disappear?
Let's see.
No, it's still there.
There it is. It's
still
on the
there.
screen.
Am I not seeing it?
Top
Oh,
row.
there it is. I see it. Okay,
Okay.
there we go.
All right. Oh, great wheel. Oh, wheel of wonder. Oh, wheel of fellow paranoia. Dr. Height.
All right,
Been a while.
give me a second.
Okay.
Go ahead and unmute yourself. See if you're.
Can you hear me?
Yep.
Yep.
Right. I'm gonna give you control here. Give me a second. Let's see. Share screen. All right, go ahead and click. Yep, you're controlling it.
Okay.
Pravir, thank you for making the arrow bigger so that people that have visually, I can see much better.
Right. So here we've got a trichrome single core. I see a few gloms. There's a decent amount of blue staining here, and I'm going to call that, I don't know, maybe 10-20%.
Yeah, Steve, yeah, that's exactly how much fibrosis there was. Mild.
Here we see one glomeruli. This looks to me like a H&E. There's a little bit of mesangial expansion here, no significant hypercellularity. These capillary loops look a little bit thickened, but pretty thin, to be honest. I don't think that I could call them really thick without, they're certainly not wire loops.
Yeah, they're not wire loops, but they are mildly thickened throughout the glomerulus.
Okay. Yeah, and I don't see any segmental scarring or anything kind of along the lines to explain like an APOL1 FSGS sort of mediated lesion at this point.
Okay.
Here we've got a PAS, again, single glomerulus. We've got, I mean, again, overall, this looks a little bit of GBM thickening, and again, not much mesangial expansion here, maybe in the center, no significant hypercellularity. As far as outside of the glom, not really a whole lot within the tubules, no significant ATN or anything along those lines.
Steve,
What
does
about,
the PAS help you with the diagnosis of amyloidosis?
It would if it was, you know, quote unquote weakly positive, but I don't really think I'm seeing that in this case.
Right, and this is something that David has pointed out repeatedly to correlate the Bowman staining on the PAS with the mesangium in these cases, and they're rather equal. So my personal reading, I'd like to hear David's input, is that this is not consistent with amyloidosis.
Yeah, I agree with you, Mario. I don't see any amorphous material that makes me think of amyloid here.
Hey, Steve, and David, could you go back one slide? I was just curious. So yeah, if you look at the top, at, I guess that is like 11 o'clock, those loops. David, what do you think about those? A little higher, those right there. Those seem a little abnormal, don't they, to you, or no?
Yeah.
Okay.
We said there's mild thickening throughout
Mild
the
thickening, okay.
I think Casey's gonna say it's exostosin, just to keep in with his lupus diagnosis.
Here we have
we go.
a Jones stain. You know, looking for spikes, holes, that sort of thing, fitting with more of a membranous type of picture. And I think that's kind of what you're seeing, kind of along, maybe along this loop here, kind of along here as well. I know that typically you'd be looking for like quote unquote a coxcomb type appearance. I don't see that specifically.
That would be an amyloid, Steve.
Amyloid,
A
I'm sorry.
coxcomb, yeah.
But these would be holes
That's
consistent
right. Yeah.
here, right? Yeah, you're seeing
Yeah.
that here as well, kind of throughout actually.
And
Holes here are so like
spikes as
visible.
well. Yeah, diffuse holes and small and spikes.
Mercury.
lots of spikes?
Okay, so here we've got a very positive, looks like granular IgG here. This to me looks like it's predominantly along the basement membranes within this glomerulus. And then along the side here, is this in the mesangial area or is this more of a staining issue?
It's hard to say when the basement membrane kind of folds over like that. We'll see for sure on the EM if there's mesangial deposits, but there's definitely capillary wall deposits.
Yeah. Okay, so I think that you're going to call both of these negative IgA and IgM, correct?
Weekly
positive?
We have weekly positive, so we got a weekly full house.
Yeah, hardly the level of IgG, but David's saying not negative, so I think that's relevant.
Yeah.
I want to ask about C3 and C1q. They are positive.
Yeah, it's there on the bottom left. C3 was 1+ and C1q was 3.
Sorry, I don't saw that.
Here we're getting to the EM. So this is kind of what I expected to see. Diffuse deposits throughout the membranous space, and I would say subepithelial in this case too, not as much subendothelial, but definitely intramembranous and subepithelial is what I would call that, specifically in this basement membrane here, seeing the same thing along the basement membrane here. And then I'm not really seeing any podocytes at all, so I would call this diffuse foot process effacement.
Yeah, and then I could see a mesangial area right in the middle, or to the left of that. Yeah, right there. Yeah, there's some mesangial deposits.
But earlier on in the discussion, the topic of MG-MID came up. So we've got to rule out the possibility of a concealed monoclonal here with light chain staining and probably a protease digestion.
And one other thing I'd like to add, and I didn't show a photograph of it, there was immunoglobulin deposition in tubular basement membranes and vessels, as seen in lupus.
Okay. All right.
You know, to me, it's interesting, yeah, just how many of those are intramembranous.
Yeah.
I mean, you could still see spikes there, but the spikes, I don't really see them associated with, subepithelial deposits so much. And they also seem, other than it's probably all this means nothing, but they just seem tiny, like a lot of tiny little intramembranous deposits. Little dots. It looks odd to me. It's kind of.
Roger, what do you think of Reverend Ockham?
Well, I think right now Occam's good.
Well, this is not Ockham. This is.
Oh no, but I don't. Well, it's not Ockham. It's
this
no.
Is this is Hickam, definitely.
Well, why is it Hickam?
Unrelated.
Because she's got ATTR genetic, and she's got ApoL2 alleles, so she's got
Fine,
three.
but until we have to see evidence she has those, but we have to see evidence that she has ATTR renal disease, or and we'll wait for the Congo red, or an ApoL1 related lesion. I mean, right now, by definition, she can have as many diseases as she wants, but I mean, if we're talking about the kidney right now, to me, this is still a singular pathophysiology that was Dr. Gash's original call, but.
Yeah, we always want to take the whole patient and not just the kidney. So
I don't. I'm only interested in the kidneys.
Well, she has at least 2 diseases and maybe 3. So I don't think Ockham applies here.
David, no fibrils, right?
I think so.
No fibrils, David?
No.
Oh boy.
Okay, so here we're seeing a close up along a GBM, again, seeing these intramembranous deposits, and it looks like there's mesangial deposition here as well.
Yeah, and there's also some subepithelial deposit just there to the left of your arrow. Yep.
This here. Yep. And again, diffuse foot process effacement.
Yep.
It's interesting how little proteinuria she had with diffuse foot process effacement and all these deposits. Again, I don't know what to make of it, but
Is it really
unless
diffuse?
this is, unless it's
David?
possibly that this was a resolving, because I mean, we're seeing much more intramembranous than we are seeing subepithelial. And maybe there was an insult. It's a thought.
I'm not sure it's
Okay.
really diffuse, but that's okay.
And I think kind of what you're trying to show is, at least specifically with this image, is that this is a TRI. Is that
Yeah.
right?
That's right.
Okay.
I presume she's a PLA2R negative.
Yes.
Yeah.
Was there a Congo red for this, Dr. Simba?
Yes, negative.
Okay.
David, are those at all organized, or are we just looking at them so high power that kind of
Yeah, no,
pseudo
they're not
organized?
organized. They're granular deposits.
Okay.
Huh.
David, do you
There
have
is fibril, and there is any fibril
No, no
on the
fibrils.
AM?
No
No,
fibrils.
David, do you have capabilities to do isotyping of the IgG?
no, I don't have that here at Rush.
Okay.
Or you're still talking about the
No, I mean, basically IgG3 is more in keeping with secondary membranous versus IgG4, which is
okay.
more in keeping with primary membranous. That's the teaching point I wanted to
Got it.
convey to the fellows.
So I think we have another.
Mayo do exostosin or NEL1 or other non-PLA2Rs if we're sending it to Mayo?
That was for you, David.
I could do it upon request. It doesn't look like anybody requested
Yeah,
anything. in
Yeah,
this case.
I think they can, for some reason, I think they only do one for some reason, but I definitely.
I think it'd be great. We talk about this every week. It'd be great if that was just automatic with every membranous. Maybe someday it will be. It'll just be a panel because, I mean, we brought up if this is autoimmune related, it's suggestive, at least serologically and historically, that would put exososin higher on the list. And even the cream is always a tantalizing possibility. And I could make the case that one and the cream stopped, and that's why we're seeing mostly intramembranous deposits, and the proteinuria isn't as high because it's going away. It's just making a case for that. Poll 3, how would you treat?
NEL1's also segmental, and this was pretty global, but
well, let me ask you that, Bill. NEL1 can be segmental, but is it always segmental?
Actually, I don't know the percentages, but I do know it's the majority of them are segmental.
Okay, that I didn't know. I know if you see segmental, you should think of NEL1, but I
Same
didn't know
with
that.
IgG1, like Mario was pointing out.
Yeah.
IgG1, NEL1.
Okay, interesting. Good points. Poll number 3, how would you treat this patient now? Would you ACE or ARB and monitor, MMF plus low-dose steroids, MMS plus belimumab or voclosporin plus or minus low-dose steroids, rituximab, or a cyclophosphamide-based regimen?
Nice scattering of responses here.
Interesting. You can show it so I can get it back to you, but we've got a tie between just watching. I mean, that was Dr. Glassick's kind of point originally. This really isn't, we got time. This patient's not nephrotic, et cetera. Or MMF plus steroids. MMF belimumab is, the other two are tied, 13%, or rituximab or MMF with or without something else. Let me ask Casey, what would you do?
Oh man, this one's a tough one. I think that I would target something that would shut off those immune complex production. So I would like to immunosuppress. So I'm gonna shy away from one. I would do some herbs for proteinuria reduction and all that, but I would go beyond that, and I would go over MMF or Rituxan. And I think in this case, I would do MMF. Because just because this never occurred in the course of disease doesn't mean, based on just proteinuria and normal creatinine, that I shouldn't be treating it. That's in fact, To prevent further damage, I think we should be immunosuppressing her. So I'm going to go with MMF here.
Anybody,
Of
Mario? what
course,
would you do?
Roger, there are no guidelines, zero guidelines that you can use to make any decision in this case.
So that doesn't mean you can't answer the question.
No, but I just want to point out for those who in the audience who like to practice according to guidelines, there are none that are relevant to this patient. So your decision-making has to be outside the framework of a guideline-based management scheme. I'm just want to, because I get a lot of questions from doctors. What am I going to do in this patient? The guidelines don't say anything about it. Well, I mean, that's real life. Well, your argument is that this patient needs immunosuppression, right? Casey?
Yes.
Because of the biopsy.
Because of those,
Not because of the proteinuria, not because of the urine sediment, not because of the serology, but purely on the basis of the biopsy.
deposits.
Okay.
Mario, what would you
The
do?
randomized controlled trial of pure lupus membranous was, by Austin in 2009 and Jason, and it randomized patients to cyclophosphamide versus cyclosporin versus prednisone alone. Cyclophosphamide and cyclosporin had relatively equal remission rates, but again, these were nephrotic patients, as Dr. Glassick pointed out, as that might not really apply here. Prednisone alone did basically diddly squat. I think it had about a 30% remission rate. So if you're going to immunosuppress, the data would suggest one of those two. But for me, when it comes down to a pure membranous, even if it's lupus or exostosin, I think there's some small case series and some ideas that maybe we should be treating our lupus membranous similar to the way we treat our PLA2R positive membranous as well. And I'm in favor of, especially when you have time on your side, of trying rituximab. But again, not evidence-based. That's opinion.
Mario just threw his hands up. Mario?
No, because I expected that statement from Bill. I mean, Mr. Rituximab. At any rate, it's interesting. I'm a firm believer in looking at activity and chronicity indexes. I've been poisoned by Bellow and Austin over the years. And in this particular case, certainly there was chronicity, there was interstitial fibrosis. And let me just say, you guys keep throwing numbers on interstitial fibrosis. I personally don't think that's right. I mean, there is actually a recent ongoing study as part of Precision Medicine, FYI, and I attended a conference at Hopkins a week or two ago where this group is a multi-center study is looking at biomarkers to better characterize IFTA. And there is also a multi-center renal pathology group that is trying to figure it out how they can reach consensus, because David calls this 10-20%. You call Helmut Ranke may call it 40%. So it's so variable that it's so hard. But at any rate, the only activity that I see are those deposits. I did not see much of reaction of the GBM, which leads me to believe this is not long-standing. And therefore, to make a long story short, I will side with Casey and go for number 2.
David, for those intramembranous deposits, I mean, those are old clearly. And so this has been going on for a while.
Yeah. Yeah.
And there's basement membrane on top of that, right? I mean, that's what was intramembranous. So
I'm sorry, can we go back to those EM pictures so you guys can show me the GBM reaction?
In fact, right there,
Where
that
is
middle
it?
one, Prabir, could go to the next one. There's mesangial interpositioning there, that cell. Go on the other side of the basement membrane. No, the other side.
Oh, other side.
Right there. That's a mesangial early mesangial interpositioning. So yeah.
So what kind of
these
stage
deposits
is
have been here
this?
for a while?
What kind of stage is this?
Well, you're referring back to the old Irish church, right?
Yep,
but from the 1950s, I think.
I'm an old guy.
Yeah. This would be what? This would be a stage 3, and if there was focally some resorption of deposits. I don't think it was shown here in the picture, but this would be a stage 3 and 4.
Okay.
There's very few new fresh deposits.
Yeah,
from what I can tell. Okay,
that's right. Yeah,
that's what I. Okay.
Does the size of the deposit suggest the age of the deposit?
not that I'm aware of.
I don't
And
know,
for those of you who are advocating MMF, how are you going to follow her response?
And that came up in the chat as well.
I think you're left with proteinuria, and you have to go very slow and
With
wait
this,
a while.
with this degree of basement membrane alteration, my prediction is that the
Proteinuria won't
proteinuria
change.
will never resolve.
Yeah.
She's had too much chronic injury to the basement membrane, so the perm selectivity abnormality is probably irreversible.
I don't know. I mean, these things do.
Oh.
They do get absorbed, and we've seen plenty of membranous patients that proteinuria will go entirely away. Now, maybe you're right that it's so chronic. Dick, what was your treatment choice here?
Mine?
Yes.
ACE and ARB.
Interesting. I'm glad I asked. I kind of think that I'd wait a little longer because I'm not sure this isn't something resolving. But if it didn't resolve, I don't know. I'm in the rituximab school these days. I just think let's just find out. Let's treat it with. We talk about no evidence. I realize that, or guidelines that's fair. But like you said, this is what we do. Dr. Lewis used to talk about guidelines, and it wasn't always favorable what he said. I think they play a very, very important point, but I think in the end that you have to look at each case individually, and go from there. I'm going to hand it back to Praveer, and he has a little bit more discussion, and he can tell us what he wants to
Yeah,
do.
no, I'm glad there's different opinions. This was an interesting one. I'm going to bring this up because I may just have to print it and keep it in my office because I feel like we talk about it every other week. But it just goes back to the point what some people have said here, and we've shown this from the Mayo series of ATTR. Really, in this series, there was no involvement. But I wouldn't equate that, and I think Dr. Reen said that. I wouldn't equate that it doesn't. It's just very rare. Of course, heart is the primary organ that we see, and sure enough, with her family history, heart transplant with her father. But in this series, there wasn't any transthyretin. But sure enough, of course,
sorry,
there's
real quick.
cases.
Praveer, sorry, go back one more time because we also talked about fat pad biopsy,
yeah.
transthyretin. So just seeing there that it's 28% or 14% on both the fat pad and the fat aspirate. That's also good information on there. Thank you.
Yeah, no, that's actually I skipped that over. That's actually important to know. So that'd be helpful. In the kidney would usually be a little less, but sure enough, I mean, I'm sure and I think Bill had a case of transthyretin renal involvement. But there's definitely plenty of stuff out there. Not a lot, but this was a recent one out of Clinical Kidney Journal in 2022, and they went back to a cohort of 103 patients. And sure enough, they did find a kidney involvement in these patients with hereditary transthyretin. They didn't go through all these 103 patients, but they did outline this one case, which I thought was interesting and almost kind of outlines the case I had. If you see a patient here, this patient had a father who had cardiac amyloid and passed away. And this patient ended up having transthyretin and with severe kidney involvement with hypoalbuminemia as well as severe proteinuria. And now this patient was treated with an ACE inhibitor, and also this is outside the scope of what I'll talk today. But there's all these new therapies that are coming out for these for transthyretin, and the whole idea is to somehow stabilize and reduce the TTR production. This one, palisartan, is one that basically is delivered to the liver, and it's thought to reduce the formation, which in this case help this patient along with ACE inhibitor. So it's not out of the realm of possibility. We've been talking about TTR doesn't affect the kidney. It definitely can. So
How often does that happen? Because Dr. Ring quoted 10 to 20%, which I think is a bit on the high side. I mean, based upon your review, how often does it happen?
It was less. It was less than 10%. And I'll go back and see. It was not as high as 20%. But what Dr. Reen said was it really depends on the mutation. And that's something I learned. There's certain mutations in the TTR gene that have much higher predilection to affect the kidney versus other ones. And sure enough, what I did is went back, and this is our patient's a variant that she had, and this variant on research is actually primarily affects the heart. So the variant that she does have that runs in her family most likely is one that affects primarily the heart with cardiac amyloidosis versus some of the other mutations that are out there, which are known that affect more of the kidney predominantly affect the kidney more aggressively, I should say, not predominantly, more aggressively than the heart. So her variant going back is not one that's typically associated with kidney involvement. That was part of the TTR. So I did have the patient get a cardiac MRI because of the family history with the TTR known variant causing mostly cardiac manifestations. That was all negative. She even saw neurology. So she has no neuropathy, no cardiac findings. All that was negative, which was good for her. And she was asymptomatic. But regardless, with that, I did send that over. The second part of her story was the APOL1. And she had 2 high-risk G2 alleles. So we've talked about she did not have hypertension, but just looking at this, just reminding ourselves, you know, she, of the 2 risk alleles, G1 really had the highest risk of kidney failure versus G2, but nonetheless, these have, of course, still have a higher risk of kidney failure and EGFR decline over time. Now, again, how this affects this patient, I'm not sure. She doesn't have hypertension, but I don't know if David's on. I thought there were still maybe 2 segmental scars that were found on the sample.
Yeah.
So I'm not really sure what that means. Is that from, you know, fallout from whatever processes had happened before, or is this part of her APOL1? I don't know. But it is important to highlight that that should be a part of, as I think Dr. Glassick mentioned, she does have this disease in a certain extent. Now, the other question I had was how does it affect in other patients with other known kidney lesions, right? So, of course, we talk about FSGS hypertension, but we're really talking about lupus. And this is from that same paper that showed the 2 high-risk alleles that I mentioned in the prior slide. You can see patients who had 2 high-risk alleles, it still crossed 1. So really hard to tell how this affects, in this series at least, patients who have APOL1 and lupus. But there is some other data out there that shows that patients who do have lupus and have 2 high-risk alleles may have a higher risk of kidney failure, especially in Black patients. And this was a more recent paper that was Dr. Friedman, Dr. Pollack in 2021 that had a nice little spectrum graph here based on their research and their review of the data. You can see, of course, we're talking about high VAN and the risk odds ratio of increased renal failure there, but you know, lupus with kidney failure, some ended up here. There was no increase observed in patients with IgA nephropathy and diabetic kidney disease. That story, again, is a little complicated because we know that it doesn't increase the incidence, but we do know that the risk variants appear to speed the progression of individuals with diabetic kidney disease. We don't have case controls studies or population-based studies, but we do think that part of the APOL1 does increase the rate of progression of those patients, but doesn't really correlate to diabetic kidney disease incidence. So just another part of her complex story. We have TTR, hereditary transthyretin amyloidosis history plus the APOL1. Ultimately, and I'm glad Roger asked Dr. Glassick, because that's what I did. I put her on an ARB for the time being. So that made me feel a little better. But, you know, it's really kind of watching closely. I think, you know, part of also looking at her is that she was very hesitant because she feels great, hasn't had any medical history. She doesn't want to do too many meds. And so I put her on an ARB. Her proteinuria went from 0.8 to 0.5. I'm still not clear on her adherence to the therapy. However, I would have a short threshold to add something if her proteinuria is worsening or albumin's coming down, and I think I would go to likely rituximab. Again, not evidence-based, but I would likely go to rituximab based on just looking at her in terms of adherence and probably the easiest, less risk profile of medication therapy for her.
Now,
Yeah, I think-
Prabir, based upon the data that you presented from Victor Pollack, do you think that the fact that she's got the 2 risk alleles for APOL1, would that fire up her lupus? And if so, should you act as early as you can with immunosuppression? I mean,
that's
I'm
the
just
question,
wondering.
right? And so, you know, I think it does. I think in general terms, I think it does. If I think she had a lot of activity on her biopsy, kind of going along to what you said. I think there is data not only based on her demographics plus the APOL1. I think she has a likelihood or a high risk of having really bad lupus. But for her, when I saw that biopsy, I thought it was a lot more chronic. And I at this point in her course, I would not, but I would have a very low threshold. If anything is changing serologically or renal parameter wise in terms of proteinuria, I would have a low threshold of adding something on.
I think that's a really good point. I mean, maybe it's just us being overly academic, but that's what we're supposed to do. And I think that it might increase the risk and it might sway you a little bit, maybe not immediately, but it might sway you a little bit to, from the watch or if something changes to treat. Dr. Reen?
Dr. Baxi, if this patient gets worse, let's presume her proteinuria gets worse, she is APOL1 risk positive. What will be your approach to that? Because I'm coming from a little bit different angle. I remember reading I think I presented that abstract from ASN, and it's a very high interferon activity with those things. So would you use anti-interferon like anifrolumab? I can't even pronounce the darn thing. That would be my thinking. That's what I would be using instead of rituximab or belimumab or anything else.
No, I don't know. That's a great question. I don't have enough, knowledge of those therapies. But the question I thought you were going to ask, if it is getting worse, is this APOL1, if she's getting hypertensive, is this more segmental scars or is this more lupus?
Yeah, I was actually second question coming back.
Yeah, well, that's the harder. I mean, that may be an easier question because then maybe you do rebiopsy and see what's going on, and I think that would be what I would do, because yeah, you're right. I don't know that at that point, or of course, as this lupus membranous become more proliferative, and you would hope that you would see something changing in the urine and etc. But I think a threshold for biopsy for this particular patient, given the complexity, I don't expect transthyretin all of a sudden, affect her kidney, but the APOL1 versus lupus nephritis would be another indication for maybe a repeat biopsy.
Wonderful. Any other comments?
Roger?
I want to comment. Sorry.
Go ahead.
Agnes Fogel and I participated in a study in the AST trial, which defined the pathology of APOL1 nephropathy in blacks. And it's not FSGS, it's global glomerulosclerosis. FSGS, when it does manifest as in APOL1, is usually of the collapsing variety. So just looking for a few segmental scars in an APOL1 positive patient is not the real lesion you're looking at. Is it progressive loss of nephrons due to global glomerulosclerosis? So I just want to point this out. That was shown many years ago in the only biopsy study that's ever been done in hypertensive nephrosclerosis in blacks who were APOL1 positive.
Good point. Dr. Aleden, you had a comment?
I have a question for Dr. Glasik about this APOL-related global sclerosis. Do you see TMA also in this situation?
See what?
Thrombotic microangiopathy.
When there is a collapsing lesion, TMA is often present. It's usually renal limited, not systemic. So there is a strong association with collapsing nephropathy of a variety of etiologies and TMA. Yes.
Mario?
Now that Dick mentioned Dr. Fogo, I think she's the one, and I am going to circle back, but I'm going to ask her about small deposits and the age of the membranous. I think she's the one that was proposing that if you find small deposits, that is in favor of a recent process, but I will double check on that. And the other thing is, for the rituximab fanatics in the audience, I have seen recently a handful of publications about the advantage of obinutuzumab in lupus nephropathy. So that is to be kept in mind if you can find it.
I think the future is is OB for everything once it becomes more
Yeah,
available.
the Regency trial was just published last week
Yeah.
in the New England Journal of Medicine, and it is the forerunner of an eventual approval of this drug and probably its addition to the standard regimens.
Yeah, I mean, it just keeps coming up for refractory membranous, for refractory minimal change, whatever it is. It just seems to be a superior drug.
Unfortunately, the Regency trial excluded patients with membranous nephropathy. So we will not have any direct information on the efficacy of OB in lupus-related membranous.
As you know, Dick, that doesn't stop us from recommending.
I know.
Data doesn't stop us from recommending anything.
And Lunar also only looked at proliferative. It had concomitant membranous, and so did OB, but it did not have pure membranous lupus.
Right, that's right.
Well, I'm going to wrap this up. That, as usual, what starts off as a simple case never ends up that way, and really appreciate the discussion. I'd like to point out, Mario was laughing because Bill always says rituximab, and his nickname is Rituxabil. But I want to give credit to our ex-fellow Dr. Dillon, who came up with a new name for Pravir, and it's Rebeximab. So I think I like that even more. So.
Hamoud, I could have used that like 5 years ago before Obi-Wan came out, right?
Obi-Wan, yeah.
All right, thanks everybody. Keep your eye open. We'll be back maybe next week, maybe not. But until then, everybody stay safe, and thanks faculty. You're so great.